There's a car with 200,000 miles on the clock and there's one fresh off the lot. You floor them both, slam the brakes, push them to the edge. One holds together, the other doesn't. Nobody's surprised by that. Yet for most of medical history, a body that had lived 70 or 80 years was pushed through the exact same operation, on the exact same timeline, with the exact same expectations, as a body that had barely lived 40. Same protocol. Same recovery chart taped to the wall. And the results were not the same. They were never the same. I'm going to tell you something that took me a long time to say out loud. The disease is often not the most dangerous thing in the room. The operation is. For an older body, surviving the surgery and surviving the recovery are two completely separate battles, and almost nobody explains the second one until you're already living inside it. My name is Dr. Mandel. For over 20 years, I have stood on both sides of this. I have opened people up and given them years they never expected. And I have also watched people walk in with a small complaint and never walk the same way again. Not sicker from what brought them in, broken by what we did to fix it. Today, I'm going to walk you through 5 operations that carry hidden, under-discussed dangers for anyone past 60. Not to scare you away from surgery, to hand you the questions that could change the entire outcome. Quick thing first, and then we go straight in. If you're past 60, or you can feel it coming up the road, and what you actually want is more strong years, your own 2 feet, your own decisions, your own life on your own terms, then stay with me all the way to the end. Everything I tell my own patients, I put into one simple plan, and it's already helped thousands of people. The link's on your screen. Nothing to write down. Just glance at it when we're finished. And if this helps you, hit like, subscribe, and drop a comment, because that's the only way it reaches the next person who needs it. Let me explain what actually happens inside an older body the moment anesthesia takes over, because this is the part the consent form skips. The heart starts working overtime just to keep up. The lungs are slower to flush the drugs out. The kidneys, which clear every medication in your system, drop into low gear. And then there's the brain. This is the one that catches families completely off guard. The older brain can come out of anesthesia foggy, scattered, not quite itself, and that fog can linger for weeks, sometimes months. It has a name that most people have never heard until it's happening to someone they love: postoperative cognitive dysfunction. In patients over 70, it shows up far more often than it's ever admitted in the office. Now hear me clearly, because this matters. Age by itself is not a reason to refuse an operation. I have watched 80-year-olds bounce off the table and heal faster than men 30 years younger. Age really is just a number. But frailty is not a number. Frailty is real, it's measurable, and it means the body's spare capacity, its reserve tank, has dropped below the line where it can absorb a serious hit. Roughly 4 in 10 people over 75 carry signs of it. Past 85, it climbs towards 6 in 10. So the real question was never, can this person survive the operation? It's, can this person survive everything that comes after? Hold that difference in your mind, because every single thing that follows depends on it. Start with the heart. Open heart bypass surgery is one of the most common major operations we perform on older adults. The logic is clean. The arteries are choked, we build a detour around the blockage, blood flows again. For the right patient, it is close to miraculous. But the brochure leaves out one detail. To do it, we have to stop your heart. Completely. A machine takes over the work of your heart and your lungs while we operate. For a healthy 60-year-old, that machine is a manageable thing. For a 78-year-old already carrying kidney trouble, a touch of diabetes, and some memory slippage, that same machine is a full-body assault landing on every organ at once. The research is blunt about it. In frail elderly patients, open heart surgery can carry a 30 to 40% risk of a serious complication. Stroke, kidney failure, long stretches of confusion, days locked to a ventilator, and here is the line that stops people mid-breath. For high-risk elderly patients, as many as 1 in 7 does not survive the first month. So is there another road? Often, yes. There's a procedure called TAVR, done through a catheter, threaded up through a blood vessel, that never stops the heart and never opens the chest. Less dramatic. Far gentler on a body that needs gentleness, not a war. Does this mean refuse heart surgery? No. It means walk in and ask one question out loud. Am I a candidate for something less invasive? That single sentence has rerouted the future for more patients than I can count. Now, the spine. If you're in your 60s or 70s, your back has almost certainly spoken up by now. I have barely met a patient over 70 who hasn't. And more, the answer being offered is surgery, fusions, multi-level decompressions, metal rods and screws running the length of the spine. Some of this is genuinely necessary, no argument. A spinal cord being actively crushed, a patient losing bladder control or the use of their legs, that is an emergency and it needs a surgeon fast. But elective fusion for the ordinary chronic ache of an aging spine is a different animal, and the evidence should give everyone pause. A major study in the journal Spine found that complex fusion in patients over 65 carried a complication rate north of 40%. Not minor complications either. Blood clots, infections, hardware that fails, and a quiet, cruel one called adjacent segment disease, where the vertebrae just above and below the fused section begin to wear out, because you locked one part of the spine rigid and the rest of the column now pays the tax forever. Here's the part that genuinely bothers me, the pain relief. For many older patients with a worn-down spine, the studies show that aggressive surgery buys no better long-term relief than physical therapy and well-targeted injections. No better, just far more risk. A spine surgeon I deeply respect once told me, "Sometimes the finest operation is the one you decide not to perform." I have never forgotten it. Have you ever been told surgery was your only option for back pain? Put it in the comments. I honestly want to see how many of you have heard those exact words. The third one is the hardest to say and the hardest to hear. Major cancer surgery. The instant a person hears cancer, the body screams a single command: get it out, cut it out, now. I feel that pull too. I would feel it about my own family. But 2 decades of this work taught me something that took years to accept. The mission was never simply to remove the tumor. The mission is to give a person more good living. And sometimes, not always, but sometimes, a massive operation on a frail body does the exact opposite of that. Take pancreatic cancer and the Whipple procedure, one of the most brutal operations in all of medicine. We take part of the pancreas, part of the intestine, the gallbladder, part of the bile duct. 6 to 10 hours on the table. In a younger, sturdier patient, it can save a life. In an 80-year-old with a strained heart and weakened kidneys, the surgery can technically succeed, the tumor gone, and the patient still slips away within weeks. Not from the cancer, from the operation. There's a name for this, futile surgery, and it happens more than anyone in my field likes to say. A landmark review from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who had these resections hit what we call failure to rescue, a complication their depleted body simply could not climb back from. So what's the conversation actually worth having? Look your oncologist in the eye and ask, if we don't operate, what does watchful waiting or radiation or targeted therapy look like for a body like mine? That question opens a door most patients never even knew was in the room. And more often than people expect, what's waiting behind it is a better life. The fourth is joint replacement, and I want to be careful here, because hip and knee replacements are among the greatest successes in surgical history. I mean that. For the right person, a new hip is a resurrection. People go from shuffling to chasing grandchildren. But notice the word elective. Elective means planned. It means nobody is rushing you. You have time to think, time to prepare, and, most importantly, time to ask whether right now is the right moment for your particular body. Because the numbers are clear. In patients over 75 carrying 3 or more serious conditions, heart disease, diabetes, kidney trouble, significant excess weight, elective joint replacement carries a much steeper risk of complications around the operation. Blood clots lead the list. A clot forming deep in the leg can break loose, travel to the lung, and turn deadly in minutes. In an older body with slower circulation, that danger climbs. Layer on the pneumonia that comes from lying still too long, and the infections that live in hospitals, and the picture gets far more complicated than a glossy before and after photo suggests. I don't say this to frighten anyone off a surgery that could genuinely give them their life back. The question is not, should I ever get a new joint? The question is my body in the best possible shape to take one right now? Get the blood pressure right, get the blood sugar steady. Address the weight, the heart, the circulation. Do that in the weeks beforehand, and the complication rates fall, sometimes dramatically. Some hospitals now refuse to schedule these operations for high-risk older patients until they've completed a formal prehabilitation program. That is exactly the right instinct. Has your doctor ever brought up prehabilitation before a planned surgery? Most people have never even heard the word. They should have heard it first. The fifth one is different, and I have to slow down here. Emergency abdominal surgery. You don't choose this one. It chooses you. A bowel that tears open, an appendix that bursts, bleeding inside where nobody can see it. These don't sit and wait for a calm chat in an office. So why is it on the list? Because knowing the risk before the emergency arrives is what steadies a family in the worst moment of their lives. Emergency abdominal surgery in patients over 75 carries some of the highest death rates in all of surgery, 30 to 50% in the most severe cases. Not because the surgeons are careless, but because an old body hit by sudden trauma is fighting on every front at once. Heart, lungs, liver, kidneys, all struck in the same instant. And the inflammation that a younger body settles within days can, in an older one, spiral into a cascade where organs begin failing one after another. It is as grave as it sounds. So what do you do with that? Two things. First, never wave off belly symptoms. Pain that won't quit, bloating, a real change in bowel habits in someone past 60 deserves attention fast. Catch the problem while it's still a problem, before it becomes an emergency on a Tuesday night. Second, have the conversation with your family now, at the kitchen table, not in a hospital hallway at midnight. What would you want if emergency surgery were the only option left? What kind of life is worth fighting for? These talks aren't grim. They're one of the most loving gifts you can hand the people who'll be standing in that corridor. All right, 5 surgeries. Now the part that turns all of this from anxiety into power, because information you can't act on is just fear wearing a lab coat, and I want no part of that for you. Before any major operation, planned or proposed, there are 4 questions every patient over 60 should carry in. Write them somewhere you'll find them. 1. What happens if I don't do this? A real surgeon gives you a real answer. If nothing dangerous shifts in the next 6 to 12 months, then you have time. Time to think, to get another opinion, to strengthen your body. 2. Is there a less invasive way? Medicine has been rewritten in the last 15 years. Robotic tools, scopes that go in through tiny openings, catheter procedures. Roads that simply didn't exist a decade ago run right through most major hospitals now. 3. What does recovery honestly look like for someone with my body? Not the average patient in a textbook. You, your heart, your kidneys, your medications, your home, your stairs. The answer should be about you specifically, or it isn't much of an answer. 4. And almost nobody asks this one. What is your own complication rate for this procedure in patients over 70? Surgeons track their numbers. They know them. A confident, honest one will tell you. If the question makes them squirm, that discomfort is itself an answer. Now let me give you something patients are rarely told, because it can shift your odds more than almost anything that happens on the table. If you do decide a surgery is right, The 2 to 4 weeks before you walk through those doors matter enormously. Surgeons spend years perfecting the procedure. Almost no one spends 2 weeks preparing the body that has to survive it. Let's change that. First, prehabilitation, the thing we keep circling back to. Think of surgery as an athletic event, because that's what it is. Your body is about to run a marathon while you're unconscious. So, build reserve. Eat more protein, because protein is the raw material your body rebuilds itself with, and most people over 60 quietly get too little of it. Walk every day, even a lap around the block, because stronger legs and lungs going in mean you're up and moving sooner coming out, and getting up and moving is exactly what beats the clots and the pneumonia. And if you smoke, stopping even 2 weeks out measurably lowers your risk of wound and lung trouble. 2 weeks. I have watched prehabilitation turn a high-risk patient into a routine one, and it costs nothing but effort. Second, the conversation almost no one has, the one with your anesthesiologist. Remember that brain fog? There are real, practical ways to lower the odds of it. Ask for a preoperative anesthesia consultation. Bring a complete list of everything you take, and I mean everything, the fish oil, the herbal sleep aid, all of it, because some of these collide with anesthesia in ways that catch people off guard. Ask whether a regional or spinal anesthetic, numbing just the area instead of putting your whole brain under, is possible for your operation. For many hip and knee procedures it is, and it's gentler on an older mind. And here's one so simple, it sounds like nothing. If you wear glasses or hearing aids, ask to keep them right up until you go under, and to have them back the second you wake. Patients who can see and hear on waking get confused far less. The research on hospital delirium is clear, and it costs nothing. Third, the piece everyone forgets until they're in it, the setup at home. Arrange help before the surgery, not after. Who's driving you? Who's with you the first few nights? Where's the bed, and how many stairs stand between it and the door? Clear the loose rugs and the cords you could catch a foot on. Fill the prescriptions in advance so no exhausted family member is hunting for an open pharmacy at 9 at night. The first 72 hours home set the tone for the whole recovery, and a body not fighting a fall or a missed dose heals faster. Watch those first days for the warning signs too. Sudden confusion, a fever, a calf gone swollen, hot, or painful. Any of those, you call. You don't wait. And fourth, get the second opinion. I know it feels awkward. People fear offending the surgeon. Let me kill that fear right now. A good surgeon expects it. A good surgeon is glad you asked, because they'd want the same for their own mother. Bring your scans and records so the second doctor is looking at the same picture. And if 2 qualified surgeons study the same body and land on 2 different recommendations, that isn't a problem. That's information, and it's exactly what you deserve before anyone lifts a scalpel. None of this is about fear. It's about arriving prepared instead of merely hopeful. The patient who shows up strong, informed, and organized is a fundamentally different surgical risk than the one who shows up frightened and unready, even when the operation is identical. You have far more control over which of those 2 people you are than anyone has ever told you. There's one more thing I have to give you, and it might be the most useful of all, because it's about reading the recommendation itself. Over the years, I've learned that how a surgery is offered to you says nearly as much as the surgery. So here are the warning signs. When you spot one, you slow down. The first is speed. You're being rushed onto the schedule. Now, if you're bleeding internally, fast is correct, move. But for a planned elective operation, true urgency is rare, and a real professional knows it. If a knee that's ached for 10 years suddenly must be replaced this month, ask why this month. That pressure is almost never coming from your body. It's coming from a calendar. The second is the single road. You leave with exactly one option on the table, surgery, and nothing else mentioned. By 70, there is almost always more than one path. Medication, physical therapy, injections, watchful waiting, a gentler version of the same procedure. If none of those even surfaced, it isn't because they don't exist. It's because nobody laid them out for you. The third, the one people miss entirely, is that "do nothing for now" never comes up. Careful watching and conservative treatment is a legitimate medical choice, and for plenty of conditions in older adults, it's the right one. If your surgeon won't tell you what happens if you simply wait and monitor, you don't yet have enough to consent to anything. The fourth is how your hard questions land. You ask about complication rates, alternatives, what happens if you wait, and instead of an answer, you get brushed aside. A good surgeon doesn't bristle at the very questions they'd ask for their own family. If those questions make the room tense, the tension is telling you something. And the fifth is a recovery waved away with cheer. "Oh, you'll be back on your feet in no time." That is not a plan. That's a sales line. The honest version sounds specific. Here's week 1. Here's when you'll need help at home. Here's the genuinely hard part. Here's what we'll watch for. Detail is a form of respect. Vague reassurance, especially the smiling kind, usually means someone is managing your feelings instead of informing your decision. And let me be fair, because it matters. None of this makes your surgeon a bad person. Most went into medicine to help, and they work themselves to the bone. But understand the system they live inside. It's built around doing procedures, it rewards doing procedures, and it runs on 12-minute appointments with no room to walk through 5 alternatives. So the tilt toward action usually isn't personal, it's structural. And the one thing that reliably cuts through a structural bias is an informed patient sitting across the desk, asking the questions out loud. So what does good look like? So you'll know it when you find it? A good surgical conversation slows down. The surgeon draws the problem out for you, sometimes right there on paper. They name the risks before you ask. They tell you, unprompted, the alternatives, and what happens if you wait. And the very best of them will say the words you're quietly hoping to hear. If you want a second opinion, I think that's wise, and here's who I'd send my own mother to. When you hear that, you've found someone worth trusting. Hold on to them. One more small thing that does more good than almost anything else here. Never go to a major surgical consultation alone. Bring someone. A spouse, a grown child, a steady friend. Here's why it matters more than people believe. In 15 years, I've watched it again and again. The instant a patient hears a frightening word, cancer, surgery, blockage, a fog rolls in. The mind bolts to the worst place, and from that second on, they barely register another word said. Later, in the car, they can't repeat half of what was discussed. It has nothing to do with intelligence. It's simply what fear does to the human brain. So bring a second set of ears, someone calm, someone who isn't the one getting the news, who can actually listen. Have them take notes, or with permission, record the conversation to play back at home when you're steady. Tell them beforehand the questions you want asked, so if the fog comes down for you, they can ask on your behalf. A frightened patient and a clear-headed advocate make far better decisions together than either does alone. Before the most important part, let me leave you with something hopeful. Because this was never a video about fear, it's about options, and they have never been stronger than they are right now. Minimally invasive surgery has rewritten what's possible for older patients. Tiny incisions, camera-guided, recovery cut short. Robotic assistance reaches a precision human hands alone cannot. Catheter-based heart procedures now save people who'd never have survived the old operations. And, beyond surgery, optimized medical management is genuinely powerful. The right combination of medications, supervised therapy, targeted injections, and good nutrition can hold many conditions steady that once seemed to demand a knife. The body wants to heal. Sometimes our real job is to get out of its way and hand it the tools. Let me tell you about a man I'll call Gerald. 71, a retired engineer, sharp as a blade. 3 separate surgeons had told him the same thing, open heart surgery for a blocked artery. Gerald wasn't afraid of the operation. He was afraid of losing himself. 2 years earlier, he'd watched his wife come out of a major surgery confused, drained, never quite the same person. He said to me, "Doctor, she went in as my wife and came home as someone I had to take care of." That sentence has never left me. When I went through Gerald's whole profile, his kidneys, his frailty score, his mental baseline, I sat with him for 40 minutes, not the usual 15, and I told him the truth. Surgery was one option. So was an aggressive medication protocol paired with cardiac rehabilitation, and for his specific profile, the 5-year outcomes looked comparable. He chose the road without the knife. That was 4 years ago. Last month, he sent me a photo. He's standing at the top of a hiking trail in Colorado, 2 granddaughters beside him, both taller than he is now, all 3 grinning like they'd won the lottery. Here's the single most important thing I'll say today. A surgical recommendation is not a verdict. It is the opening line of a conversation. You are not a passive recipient of decisions made about your body. You are an active participant in your own care. The moment you step into that office, you have the right to ask every hard question, to request every alternative, and to take every day you need to decide. The surgeon holds the scalpel. You hold the choice, and that choice, made with full information and clear eyes, is the most powerful tool in all of medicine. More powerful than any operation I have ever performed. Let's pull it together. 5 surgeries carrying serious hidden risk past 60. Open heart surgery in frail patients, where gentler alternatives now exist. Aggressive spinal fusion, where the promise of pain relief is far thinner than most patients are told. Major cancer resections, where the goal must always be more good years, not just a removed tumor. Elective joint replacement in seriously ill patients, where timing and preparation matter as much as the surgery, and emergency abdominal surgery, where your best protection is catching trouble early and talking honestly with your family before the crisis ever comes. And none of this means avoid surgery. Surgery saves lives every single day. I have seen it, I have been part of it, and I am proud of it. The message is simpler than that. Be an informed patient. Ask the hard questions. Request the alternatives. Get a second opinion, and a third if you need one. Your age is not a weakness. What's the one question you'd most want to ask your surgeon before a major operation? Tell me below. And if this helped you, or someone you love, think more clearly about a surgical decision, share it. That one share might be the most important thing you do all week. Take care of yourselves. Stay curious. Keep fighting for your own health. You deserve a surgeon who explains everything and a team that treats you as a partner. One last thing. Everything I've shared today is general information, drawn from published research and years at the table. Every person is different. Before you decide anything about surgery or treatment, sit down for a full, honest, unhurried conversation with your own doctor. They know your history. They know your body. And that conversation, direct and calm and unrushed, is exactly where good medicine begins.